Chairperson, distinguished guest, and learned audience, Assalamu alaikum and very good morning. This is Dr. Naznin Umme Zakia, Associate Professor, Pediatric Cardiology Department from NICVT Dhaka. Welcome you all to this presentation. It's a case summary of a 4-year-old girl of a non-consanguineous parents presented with recurrent respiratory tract infection, head sweating, and growth failure since 6 months of age. She had bounding pulse, continuous murmur in the left infraclavicular area, and having cardiomegaly and plethoric lung field on chest X-ray. Echocardiography showing a large 4.5 millimeter PDA with left to right shunt with hyperkinetic pH, severe pulmonary arterial hypertension. We did CT and showing the PDA, length of the PDA was 10.5 millimeter, 4.6 millimeter is the diameter, is connecting aorta with the pulmonary trunk, and diameter of the ascending aorta, arch of aorta, and descending aorta is normal limit. This is the device closure is done with the amplasar duct occluder. This the lateral image is showing the good anatomy of the PDA, ductal and showing the size, shape, and we selected the 8/10 size device. It is deployed into the duct through delivery sheath, and after deployment, post-procedure angio showing the good position of the PDA with minimum trickle of flow through the device. And follow-up done at immediately after 24 hours, after 1 month, 3 months, 6 months, and so on. At 1 and 3 month follow-up, device was in good position, and there is no LP and aortic obstruction. But at 6 months of age, there was a significant aortic obstruction, and the peak pressure gradient was about 45 millimeter of mercury, and narrow segment measure about 3.2 millimeter. And so we planned for re-intervention, and patient is prepared for balloon angioplasty and stenting after good discussion with the parents and good discussion of whole team. As well as right femoral artery was accessed under general anesthesia, and narrow segment was measured. Crossed with a JT Terimo wire with a Judkins right coronary catheter, and pull-back pressure gradient was measured. It was about 40 millimeter of mercury. And then lateral angiography was done with a 5 French pictal catheter, and you can see here there is a narrow segment in the opposite to the occluder. Possibly it is because of the encroachment into the lumen of the aorta, and then some measurement was done here. This is the narrow segment was 3.3 millimeter opposite the duct occluder, and proximal and distal measurement was taken, and length of this total segment was, narrow segment was taken for determination of the site, diameter, and length of this stent. Finally, we have decided to implant a 8 into 18 millimeter long value biliary stent, and it is a pre-mounted stent on a low profile balloon, 8 into 4 centimeter balloon size. It was implanted through a small caliber sheath, 7 French, over a 0.035 amplasar stiff wire, and that is anchored into the right subclavian artery. And this is the image showing this balloon stent assembly is placed in opposite the narrow segment. And then the balloon, the stent is dilated gradually with slow controlled de-wasting with a low nominal pressure. And it is dilated gradually until de-wasting of this center of this balloon. Then we removed the balloon and wire from this and we can see here that there is a good position of this expanded stent in position with good caliber, vessel caliber, and there is increased flow through this narrow segment, and pull-back pressure was measured. It was about 12 millimeter of mercury. And follow-up is done after 24 hours, and we can see there is good position of the stent here, and there is significant reduction of this peak pressure gradient. It is about 15 millimeter of mercury after 24 hours. And for each patient, this patient was followed up regularly after 1 month, 3 months, and 6 months. And she was heparinized after post-procedure for the 24 hours, and she was given aspirin after on discharge. So some points about this Value biliary stent. This is a stainless steel open cell stent pre-mounted on a low profile balloon, and it have got the capacity of high flexibility and ability to redilate to larger diameter without shortening to match the growth of the child. And it have got different diameter and size, and can be used in smaller caliber sheath, because as we know, the aortic coarctation can be treated with stenting in older children having weight more than 25 kg and more than 10 years, and have to use larger sheath. But this stent can be used in smaller sheath and can be redilated to up to larger size to adapt the growth of the child. So the aortic obstruction can occur. It's a rare but serious complication, should not be ignored. It occurs because of the smaller aortic dimension, poor arterial elasticity, inherent abnormality of the isthmus, regression of the ampullary space, constriction of the ductal tissue encircling the isthmus, and migration of the device edges. So needs serial follow-up to see any evidences of obstruction. And it should be treated and detected immediately. And stent implantation provides an alternative option to surgery, and use of value stent suitable for smaller such subgroup of patients. Thank you for patience hearing.